Hello, everybody. Thank you for giving us the opportunity to present our experience and our opinions regarding the production of epidemiological data on pesticides and population health. So we are two epidemiologists from Public Research Institute in France, Pierre Lebailly from the Cancer Research Center in Caen, and myself from the University of Bordeaux, and we both work for INSERM in research teams. So we'll have a two-voice talk presenting together the methodological basis, which we believe are important to recall, and illustration from the Agricon cohort, which follows around 180,000 people in agriculture in France for almost 20 years, in particular to follow the occurrence of cancers and the role of pesticides in this disease. So the discussion of these 2 days are very important if we consider that we wish to achieve important messages and regulation for public health, including in the field of pesticides, which is our research topic. We all know the very important messages that are disseminated in areas as diverse as cancer screening, the danger of smoking, or the risks linked to alcohol or to chemical substances such as lead. But we must remember that all of these messages, and many other ones, exist today because of data that are provided by epidemiological studies. Indeed, it's really crucial to calculate the increases in risk in relation with exposures so that preventive actions and regulations can be developed. This is where scientists have to inform public health decision makers. We also know that this knowledge and the messages are at the heart of social debates. So to be understood by everyone, the prevention messages on pesticides have to keep simple, but this must not give the illusion that the methods and concepts are simple and that everybody can tell he is an epidemiologist. So, the first complexity in epidemiological approach is the various study design that can be used. We have talked about this for the 2 days, but frequently non-epidemiologists say that there is a representation of the design, which is the best design is the cohorts, and the other ones don't provide reliable results or really less reliable results. But as epidemiologists, we know that this representation is wrong and that all designs are valuable and useful. There are situations where cohorts are more appropriate and others where it is case control studies or even cross-sectional studies. Issues like the research question, the frequency of exposure, or the incidence of the disease must be considered to choose the best design. And actually, the complete understanding and conclusions on a question frequently result from the combination of studies with different designs in different populations. This is why collective expertise or reviews on the question of pesticides and health must include a range of studies with various designs. Not only meta-analyses have to be considered, but also individual studies, whatever the design.
So we would like to show you some basic examples of how several types of studies are useful to increase our confidence on results. Cohort and case control studies are sensitive to different types of bias. Some of the, here we have one side here. It's not the, yeah, okay. Okay, sorry. It's one big cohort among farmers and the Agricon cohort, and we've got two ways of measure exposure for smoking about the link with lung cancer. And when you look at the other way, 14 case control studies managed by IARC and in general population. And what we can see here, the association between lung cancer and smoking was consistent across both studies with various study design and population, farmers and general population, in the conclusion and in the strengths of association and the dose-effect relationship between the two.
So a second complexity in epidemiology is the interpretation of the results. Non-epidemiologists often say that if results are not statistically significant, they must not be considered, or nothing can be said. They refer to the p-value equal to 0.05 of the statistical analysis. But epidemiologists know that this p-value is only a convention. This is the risk value that we accept to take to wrongly conclude when that there is a difference. 5% is commonly accepted, but many other values could be also. Actually, the context should be considered when choosing the value. Maybe it has to be very low when considering the danger of, or the efficacy of new treatment, but could probably be higher when considering risks associated to occupational exposures. As concluding wrongly doesn't represent a danger for the population in this case. There is no health risk to withdraw an occupational exposure, while not withdrawing could be associated to a risk.
Okay. So quite recently, a wide group of researchers published recommendation to change the way statistics were used. It was published in a small and low impact factor journal. Moreover, it was already published several years ago by the American Statistical Association. So in the small paper, Nature paper, they took several examples of wrong interpretation of results considering only the statistical significance to conclude to inconsistency between two studies. So you can see here. Here you've got the example of the study, exactly the same strengths of association, and the authors of this article say there is inconsistency between the two studies because one was statistically significant and the other was not. It's just silly to say that. So they look at almost 800 of articles, and for half of them, the interpretation was wrong, just based on this silly way of use p-values. So if we look at the conclusion, the conclusion of this article, we are calling for a stop to the use of p-values in the conventional dichotomous way to decide whether a result refutes or supports a scientific hypothesis. So the third, maybe you can go. So for one journal, one of the best journals in epidemiology, in fact, one of the journals, and we have to take into account when we review articles to see where it was published, because the reviewers are not the same for the different studies. So at the moment, we did not see this that was considered for the tools you use. So maybe it's useful to discourage using the term statistically significant as well. So
the third complexity in epidemiological approach is how sources of errors are considered. We have discussed this a lot these 2 days. We frequently hear non-epidemiologists saying that epidemiological studies can never reach final conclusions because of bias. This is really something we hear, and that other parameters can explain the links when associations are found. As epidemiologists, we don't agree with this view. Indeed, epidemiology is among the few disciplines that to seriously consider the risk of drawing false conclusions. But for all disciplines, this is a problem. Because epidemiological studies are observational, it is important to include all relevant factors in the calculation, and this we can do today. More generally, actually, most biases, selection, information, and confounding bias, can be controlled thanks to the quality of study protocols and the use of appropriate statistical methods. We can say that epidemiology integrates the complexity of life, and this shouldn't be seen as a limitation, but as a strength. As the conclusions are reached under real conditions, they are directly useful to population.
So basically, as it was shown previously during the topic, So you've got, you need to have two conditions to have confusion. So association with the disease. So for example, here you've got the lung cancer, and you've got farmers. Farmers, in many studies, you have a decreased risk among farmers of lung disease, but the smoking habits is well known to be related with lung cancer since many decades, and the strength of the association is very big. So if you look at this crude estimate of exposure, only the job title, so you have a relationship also, so you can conclude to a confusion, to some confusion. But if you look at a specific exposure among farmers, it's less obvious that you will have a link between this typical exposure and smoking. So if you look at this study, it was not in the article, it was asked by reviewers. So it was supplementary data we provided to the reviewer of the article. So if you read this article, you won't see that, okay? So you've got the relationship, decreased risk of lung cancer with an increased duration of cattle farming. Here it was adjusted for pack years of cigarettes, you have the decrease, and here it was not adjusted. And the trend is exactly the same. So sometimes you don't need to have adjustment. It's not useful to have. Okay? And for another question concerns the accuracy of exposure assessment. In opposite to what was said several times during this meeting, HEPI studies rarely relied on a single exposure measurement. Not only biomonitoring provides exposure information, questionnaires are most often used, especially for studies on cancer risk, and can be very reliable. In the African cohort, here, we have the same questionnaire, which was answered by 700 farmers twice at 1.5 years ago. And for example, here, on very important parameters, the exact year of use of herbicide treatment on grassland, you can see the intra-class correlation for the exact year when they start and the exact year when they stop to use pesticides. So it's quite relevant, and it's well higher than 0.6, okay? Even among farmers, okay? And still on exposure assessment, increased cancer risk among farmers is usually considered to be low. We think that it depends on the way exposure is defined. For example, in agriculture, when we look at the association between fruit growing, here, so you've got, yes, farmers were involved in fruit growing during their job life. You will see almost no effect on cancer, prostate cancer. When you take into account the duration of fruit growing, so you can begin to be higher than 1. And when you take into account some task and the duration of the task, you can go to a doubling of risk because you have a more accurate exposure assessment.
So another complexity in the interpretation of epidemiological results is the causality judgment. Some non-epidemiologists think and say that if there is no biological explanation to epidemiological results, then they mustn't be considered. But the reality is that mechanisms may be complex to identify, and there are many illustrations of this in the public health history of important epidemiological results with no biological explanation. This was the case in the 50s for the Minamata disease. The identification of methylmercury required several years, and in the meantime, the number of cases of the disease became very, very high, very important. For arsenicals and cancer, epidemiological facts are well established, while the mechanisms are still not completely clear. So we can say that sometimes toxicological knowledge comes first, but in other times, it's epidemiological knowledge first. Biological plausibility is neither necessary, neither sufficient for causality judgment. Decisions can really be taken and must be taken sometimes in the absence of mechanisms knowledge.
So we have to be humble about the level of knowledge on biological mechanism. We have a complex disease like cancer, for example. We can observe that in the past 2 decades, we came from only 7 hallmarks of cancer to 14 now. And we are not able to all be evaluated before marketing of products. And some of the hallmarks are clearly still to be discovered. So, and to conclude, what we can say is that epidemiological methods are more complex than they seem, and dealing with bias is our duty every single day. So we are aware of bias. Evaluation of observational epidemiological study and their interpretation must be done by analytical epidemiologists, even if discussions are necessary with risk assessors. And even most refined tools for risk of bias cannot replace the knowledge of people who made the studies or those reviewing papers, because when articles are published, they are being reviewed by the experts of the field. So epidemiological, it's real life. Results can provide causality judgments. In occupational health, the aim is to avoid harmful exposure, and even if p-value is higher than 0.05. Many epidemiological results could be very useful in the view of pesticide regulation, as well as field data on exposure. We have no time to share with you, but some of the posters from our students could do it. So thank you for your attention.